All right, I guess we'll go ahead and get started. So thank you to so many people for getting going on a Saturday, joining us on a Saturday or early Sunday, I guess, if you're contacting us from the Far East. And I am excited to get going. Just a few housekeeping points to start with. Obviously, this whole session is geared towards our understanding SMA and dealing with and helping people living with SMA better. And that's the thrust. We hope you're picking up some things, but we hope you're also giving us some feedback in terms of what we can do going forward. We are eager, if there is an interest, to do this again, but want to obviously meet the needs of the community. So we can't do that without our sponsors, and we're really grateful. I wanted to mention again for the support we've gotten from Biogen, Ionis, and Scholar Rock. It's been an absolute joy to work with these companies and others to bring the new treatments online, and we're looking forward to new treatments yet, continuing to improve what we can do to help people living with SMA. I did want to point out that we are hopeful that you're rating each of the sessions you're listening to currently, that you can do that. There will be another overall evaluation form sent out at the time that you get your CME credits for this, or after the course is done. And so we'd love to get an overall perspective, but maybe you have some ideas of things that you wish had been covered or you thought were good to cover, or maybe amplify, and can give us that feedback right away. So please go ahead and rate the session and jot down any ideas you have of what we could do better. So that's something you could be doing now, and we'd appreciate that feedback. Today's session is set up like the others. We'll have our plenary session to get started here. And then we'll go into the breakout sessions so that we are eager. Those have gone very well. And then we will be ending the breakout sessions promptly at 10:50 or 10:55 if things get moved back by 5 minutes, so that we can all reassemble for a final plenary session at the end, which should be great. And I really encourage you all to come back on time, because that's when we'll be getting the perspective from a couple of patients and what it's been like to live through this with them. So I think it'll be good. I did want to point out that we will be posting videos. So if, for instance, you were in the physical therapy breakout session yesterday and you really wished you could have heard what was discussed in the occupational session or in the speech and language pathology session, all those videos should be up online. They might not all be up online today, but hopefully within the next day or so you can log back in and listen to things that you might have missed. So we'll try to have all those videos up. They should stay on the Whova site for another month or a few months. We're not exactly sure how long, but by the time they come down from Whova, they should be all up on the Stanford CME site so that you can gain access to them that way. So we encourage you to take advantage of the great talks that have been given. I do want to issue again an apology to all the speakers, because we've asked you to give way too much material in way too short a time. So you've had to condense this down, and we really appreciate the tremendous talks that have been given and all the effort that's gone into it. So without further ado, I'm going to pass the baton to the speakers of our first session, which will be on SMA. So we're going to be hearing about on newborn screening of SMA. So we're going to hear about the impact of newborn screening from Carly Siskin, who's a clinical associate professor of neurology and genetic counselor, and the first person who joined me here when we started the new era of neuromuscular medicine at Stanford, and Mary Schroth, who's the chief medical officer at Cure SMA. So I will stop sharing my slides and Carly can start sharing hers, and we're off and running on newborn screening. Thanks a lot.
Thanks, John. I appreciate it. Let me pull up my slides. And so it's really a pleasure to get to talk to you about one of my pet projects I've been so fortunate to be able to work on here at Stanford and with the state of California, and being able to see newborn screening actually come to fruition here has been really quite a joy. And so I'm just going to give you some of the few impacts that newborn screening has had in a few different areas. It's my disclosure. And the areas of impact for newborn screening that I'll touch on are going to be the way that they impact families, clinicians, and genomic equality. So you all have heard about how people with SMA have SMA because they have an absence of SMN1 protein being formed. So usually when we're talking about people with SMA, we're talking about this person down here, the affected person. But in order to talk about newborn screening and talking about families, really need to talk about the way that a person inherits it. How do they get to be this one person? How do they get to have the absence of SMN1 protein? So this is my little picture of the way that this tends to happen, is that in most cases, people are carriers where they have one copy of the SMN1 gene and the other copy of their chromosome is missing that gene. In every pregnancy, a person will pass down one copy of their chromosome and their partner passes down the other copy of the chromosome pair, which means that in every pregnancy, there is 4 different possibilities that can happen in the offspring. And while we usually talk about the affected child when we're talking about SMA, there really are all of these other people or possibilities that need to be talked about when we're talking about the impacts of SMA. There's also other pieces of this that are important to keep in mind, because often, or always, I guess, when a person is having a child who is identified on newborn screening as having SMA, that means that they are of childbearing age. And so that may not be their first child and it may not be their last child. So there may be other children that are involved in the family, or there may be other pregnancies that the family wants to pursue. And so the question about, will I have another child, or do I already have another child that's affected with SMA, is an important one. And there's a few pieces here that need to be discussed. So one is that most of the time, the parents will look like this, that they have one copy of the SMN1 gene and the other copy is missing. And when they have carrier testing, they find out that there's one copy of SMN1. However, it is also possible to find out that one of the parents has 2 copies of SMN1. And there's a couple of things that could be going on there. One possibility is that they have a brand new de novo variant that has changed their SMN1 into something that works like an SMN2, or a gene conversion event, where their SMN1 protein is no longer working in the same way, but rather is working like an SMN2 gene. And so that has happened in 2% of people who are affected with SMA, that their parent does not show that they are missing the SMN1 gene, but rather the child inherited this gene conversion event. And the other possibility is that the parent shows 2 copies of SMN1 because they have 2 copies of it on the same chromosome. And this occurs in about 4% of people in the general population, where they have 2 copies of this gene on one chromosome and 0 on the other. And so their genetic testing can't actually tell which chromosome the gene is on. All it shows is how many genes are present. So by having a test that shows that a person has 2 copies of SMN1, that is not enough information to actually say that they are not a carrier. There are some additional things that can be done to figure out the risk a little bit more, but that's not really the point of my talk today, so I'm not going to go into that. But the one other piece that I also want to mention is that in some cases, the person will have SMN1 gene, but there is a mutation within that gene. So it isn't this absence of the gene or absence of the exon 7 that is causing the SMN1 protein to not work, but rather another mutation someplace else within the gene. And that is true in about 5% of people who have SMA. And those types of mutations are not picked up by the newborn screen. The newborn screen, as we heard yesterday, is a genetic test. It is measuring the number of SMN1 genes present in a person. And it is only positive if a person has 0 copies of SMN1 or exon 7 of SMN1. in which case if a person has one copy of SMN1 and is a carrier, those are not reported out. But if their other copy of SMN1 has a mutation in it, that person will not be picked up by newborn screening. And that's an important piece too that I'll get back to when we're talking about the impact of newborn screening on clinicians. So this impact affects people and affects families really significantly. We talked yesterday about having a newborn baby with a really scary diagnosis, that you find out that your brand new baby who looks perfect has the #1 genetic killer of babies. And that's terrifying. But then you find out that there's all these different therapies that are there. And so that is very hopeful. And then you find out you need to have the AAV9 titers taken to see whether or not you can have the baby can have gene therapy. And then you find out the AAV9s are too high. And so you can't do gene therapy right now. And so now you're making a decision about if you're going to do risdiplam or you're going to do nusinersen. And there's just a lot of roller coaster of emotions that go along with getting such a diagnosis at a newborn stage. And like we heard yesterday, not every family is going to agree that this is something that's affecting their child and be willing to pursue testing or even confirmatory testing or treatment of a child who has this diagnosis. And this, again, has a big impact on families. And so how do other family members deal with this? And the way that I look at this is when there's a new diagnosis in a family, in a baby through newborn screening, the first thing that I'm going to end up doing is testing the parents and seeing if they're carriers. But as I mentioned, there's all of these caveats about whether or not a baby is going to have a mutation that they inherited from a parent. So even if the parents are found to, if one of the parents is found to not be a carrier, I'm still thinking about testing the other family members, which includes siblings. It includes aunts and uncles of the newborn baby, cousins, grandparents, whoever thinks that it might be useful for them and their potential family planning options, or perhaps for other children, then that's a really important piece that needs to be included. There was this German group who published a case series about families who were identified through newborn screening, and it was specifically focused on people who had 4 copies of SMN2. And in 2 of the cases, newborn screening diagnosis led to a diagnosis in a mildly affected older sibling that was identified because of the new diagnosis in the family. So you can find these other cases. You can have older siblings that end up being affected and also need treatment because this newborn screen has identified this person. I have had families where I have tested 11 different family members to see how this is affecting people, because it does have implications for perhaps other children and also for future pregnancies, if that's of concern to people. There is a big impact on clinicians as well. And some of this was also mentioned yesterday, so I'm going to breeze through most of this, but there have been updated treatment recommendations saying that people who have 4 copies of SMN2 should be treated with gene therapy. And part of that is coming back to this German paper where they found they had symptomatic children who had 4 copies of SMN2, and we've seen that in our clinic, and there's been a huge case series put together by the California clinicians saying, like, these are the number of people who have 4 copies of SMN2 but are showing symptoms in early childhood, and that's a case for them needing to have gene therapy at birth even though they have 4 copies of SMN2. And this idea that perhaps somebody will be lost to follow-up and won't get a chance to get therapy at the time when they're showing symptoms. And time is neurons. If you don't get the testing or the therapy done as early as possible, then that causes lifelong issues. There was also this discussion yesterday about how the types of SMA have really been changing. And we have previously named them SMA type 1, type 2, type 3, type 4, and it just doesn't apply anymore for these people who are having newborn screening, so that because these treatments are altering the natural history of SMA. And now people are talking about what treatments have people received, what's their motor function at the time of treatment, what's the highest level of motor function that they've achieved. And that's really what we're doing here. And today in this symposium is talking about non-sitters and sitters and walkers to describe SMA. And when we all worked with the state of California to set up the newborn screening and setting up the system for how we're going to report out the information about the kids back to the state, we eventually came to this agreement that we aren't going to use types. We're going to say the person has SMA. And I think that's what we're going to end up in the future, that it's just SMA. And I mentioned already that newborn screening identifies 95% of people with SMA, but that means that kiddos might report to a doctor and the doctor might assume that the newborn screen was normal. And so that person has already been tested for SMA. And so whatever weakness that person is showing is not due to SMA, but 5% are going to be missed through the testing. And so they need to have full gene sequencing to see if they can be found to actually have SMA. And so education is really an important part for the state and to give back to the doctors and other providers so that they know that this is still a possibility, even though newborn screening has been performed. And finally, I want to get up on my soapbox because this is, I want to talk a little bit about genomic equality. 2020 has really been a banner year for social justice, and that this has not escaped the notice of the genetic community as well. And the idea that a lot of genetics is really rooted in the Caucasian population. And newborn screening gives us an opportunity to really level the playing field in the way that we talk about things. So here's my example of how this is true. When I have talked about carriers of SMA in the past, I've usually used a carrier rate about 1 in 40. And I think in general, a pretty well accepted number for carriers is 1 in 50. So let's say here, this person has a 1 in 50 chance of being a carrier. And so does their partner. Because each person is going to pass on 1 copy of a chromosome in every pregnancy, it ends up being a 1 in 4 chance of having a child that's affected with SMA. So the number ends up being then that 1 in 50 times 1 in 50 times 1 in 4 equals a 1 in 10,000 chance of having a child born with SMA with no other prior knowledge. But those numbers are really based on the Caucasian population. So what does this look like if we're expanding the way that the numbers in the carrier frequency? Well, in the Asian population, it's about 1 in 56. So then we're talking about a 1 in 12,500 births. Or in the African-American community, it's 1 in 91 people. And then you're talking about 1 in 33,000 births. Or in the Hispanic community, 1 in 125 people are carriers, in which case you're talking about 1 in 62,500 births. So how does it actually pan out in a real world setting? Well, here's the number of births that were had in California in 2018 based on information from the Kaiser Family Foundation. And excuse me, based on each of those same groups and the carrier frequency and the expected number of births, multiplying that through, you can see that you get this expected number of births would end up being about 22 or 1 in about 21,000 births. And this is really the numbers that are being seen. It's very close to the number being seen in California, which is about 1 in 19,000 right now. It's very similar to the number in New York, which is about 1 in 21,000. And so I am going to argue that our number, or at least my number of 1 in 40 or 1 in 50 is not reasonable, and that a better number should be 1 in 72. And that is something that newborn screening is able to give us, and it's able to give us this unbiased, non-ethnically or race-based number that we can provide carrier frequencies for a general population. And it's not a huge deal, but it's one small step towards reducing inequalities in genomics. So I will get off my soapbox now, and I will turn this over to Dr. Schultz to talk more about newborn screening.
Mary, we can't hear you.
Thank you.
Good morning, everyone. I'm Dr. Mary Schroth with Cure SMA. I'm going to talk to you this morning more about newborn screening. I want to thank the organizers, Dr. Day and Dr. Dunaway Young, for the invitation to be able to share this information with you this morning. I have no disclosures. So I want to start by giving you some history about newborn screening being added to the recommended universal screening panel. The first submission actually was back in 2008 to the Advisory Committee on Heritable Disorders in Newborns and Children, but that submission was rejected because there was no state pilot and no approved drug at that time. Then Spinal was approved in December of 2016, and in February, a request to add SMA to the recommended uniform screening panel. It was resubmitted. It was accepted, the work was reviewed in May of that year. There was lots of deliberation, discussion about this, and final decision was that it was approved to add SMA to the RUS in July of 2018. So as you've heard, 95 to 98% of infants are identified by newborn screening, but it's critically important that we keep in mind that newborn screening does not capture every child with SMA. Having a negative newborn screen for SMA does not rule out SMA. So we just need to keep that in mind as we continue to move forward. Clinical suspicion and diagnosis of SMA or consideration of SMA in hypotonic children will continue to be critically important. And just know that the testing for SMA for newborn screening is based on SMN1 copy number, as you've heard from Carly and previous speakers. But also some states are including SMN2 copy number testing. And on average, a child with SMA is born every day. So what happens when there's a positive screen for SMA? Well, it requires an urgent emergent referral to a neuromuscular center. And centers are identified by every state's public health lab that performs the newborn screening for SMA. They've identified the referral centers. Depending on the state, those centers are notified along with the primary care provider regarding a positive newborn screen. But they have generated a list of who those centers are. And when those children are referred to the neuromuscular center, confirmatory testing has to occur. This is a screen. Newborn screening is a screen. So confirmatory testing happens for SMN1 and SMN2 copy number. Treatment options are discussed, and they receive genetic counseling from wonderful genetic counselors like Carly, who spoke prior. And I want to reiterate, too, that suspected SMA is a clinical emergency, whether it's newborn screened identified or whether a child presents with hypotonia. Time is neurons, as Carly said earlier. And we know from the clinical trials and from real world evidence that early treatment results in the best outcomes. So this is our current status. There are 33 states screening for SMA, and this represents 68% of all infants in the US. This has been our progress over time. In comparison to SCIDS, which was added to the RUS in 2010, it took 5 years to get to 33 states screening for SCIDS, and we did it in 2. That is just tremendous work, and I want to thank everyone in the SMA community who's been advocating for SMA newborn screening. So at Cure SMA, we track the incidence by state. We are in communication with the public health labs, sharing information with them, providing them with materials and supporting them based on their needs. And we ask that they share back their incidence rates. And of 23 states that are reporting to us, of the 33 states that are screening, and the previous slide were the permanent screening states, there are 27. This slide shows you that there are 5 pilot screening states. And of the 23 states that have reported information back to us, there's 2.3 million infants who've been screened since January of 2018. And this represents 171 infants who are SMA newborn screen positive. And of those 171 infants, 101 families have contacted us. And we thank you for referring those families to us so that we can provide support to them. So based on the information that we have thus far, the estimated preliminary incidence is 1 in 14,000. Now, Carly just shared that in California and in New York, the incidence rate is 1 in 20,000, but we also have states that have an incidence of 1 in 5,000. So it is quite varied across the US, those incidence rates. And stay posted. We're continuing to gather this information. I also wanted to share with you what the resources are that are available through Cure SMA. So when families contact us, we ship out a package of all kinds of materials, educational materials. We have newborn screening booklets that we share with centers and with the state labs. So taking a backtrack a little bit, these newborn screening booklets, they're designed for families and also for primary care providers. For families, we have our Care Series booklets, which give an overview of spinal muscular atrophy. We've recently updated the Understanding SMA, the genetics booklet, and the nutrition booklet. And if you want these materials for your clinics, please contact us at patientcare@curesma.org. As part of the information package, families receive all these other materials that Cure SMA produces throughout the year. We have a compass, which is focused on research, clinical care, our directions, which is directed at families, our annual SMA conference, and we provide scholarships to families. This last year, we did our meeting virtually. And we're trying to determine what we will do next June, whether it will be a virtual or in-person meeting, so stay posted. And we have other resources that we provide. This is pictures of the care packages that we send out to every newly diagnosed family. These are the care packages that babies identified by newborn screening receive. And families love these. We send these out within 24 hours of being contacted. So again, I encourage you to refer the new families to us so that we can provide materials, educational materials and support and help bring them into the SMA community. I also want to share with you the Cure SMA awareness campaign regarding clinical presentation of SMA. So this is a website. It's Smart Moves at curesma.org. And this website has videos of symptoms of SMA. The materials are for families as well as primary care providers or training programs. It's really a beautiful program. I encourage you to go in and look at this. It helps to bridge the gap until SMA newborn screening is in full implementation. But as we keep reminding you, 5% of babies will not be picked up by newborn screening, and it will be important to continue to have resources and awareness regarding what the symptoms of early SMA are. There's also seaming activities associated with that. And we have a one-page quick reference guide and I want to share with you a story. We had a family contact us from Montana who the mom had concerns about her baby, Googled and found our Smart Moves site, and then would look through it and identified that her baby fit many of the things that were described. And she took the information to her primary care provider in rural Montana, and the baby was subsequently diagnosed with SMA. So this is a powerful tool, and I encourage you to look at it, use it, share it out with your trainees and primary care referrals. So one last piece I want to share with you is that Cure SMA is collecting data about families whose child's been identified by newborn screening. And we're collecting data from families. Families are entering information. They're answering approximately 20 questions. And we're also asking their healthcare provider to answer questions as well about the child. Families sign a consent and then go into this portal. So I encourage you to share out this information. We currently have 29 infants that are in our registry, and this is the breakdown based on copy number. And with that, I will turn this back over to program organizers. Thank you so much.
Actually, Mary, why don't you keep your slides up, because we have a question for you.
Okay.
And that's,
Thank you.
what states don't have newborn screening, and what are the barriers to preventing that?
Oh, fabulous question. Thank you so much. Let me go back to so the dark blue are screening states, the light ones are the ones that are not screening. So, so there's multiple things that are involved in getting newborn screening implemented at the state level. Keep in mind that the federal RUS is recommended. It's a recommended uniform screening panel. So then it's up to each state to implement newborn screening. California has it legislated that within 24 months of a disorder being added to the RUS, they need to implement it. And John Day, please correct me if I don't have that quite right, but that is our understanding. And there are other states that have that legislated. Most states do not. So that just makes it more challenging. So the issues that come up are legislative rule changes that need to happen, finances. COVID has been very challenging for these public health laboratories, managing the COVID situation, along with continuing to move forward in developing their assay for SMA newborn screening. And then we've also encountered states who are challenged with identifying the referral centers in their state. So when a baby's identified, where does that baby get referred to? So we're working with state labs. So the largest state that remains is Texas, but Texas is slated to implement newborn screening in June of 2021. And we have a plan. We anticipate being between 85 and 90% of all states screening by the end of 2021. And we expect full implementation by 2023 at the very latest. So I hope that answered your question.
I will say that I was amazed at how much work actually needs to happen in order for the states to implement the newborn screening. I had no idea all the things that went into it, and I couldn't believe it was going to take 2 years to actually start it. And then we started seeing the timelines of how all the things that California needed to do in order to get newborn screened added. And we're like, okay, I guess you actually need the 2 years to actually get it up and going. And it's hard to do. It's a lot of work. So all your points are really well taken.
Yeah, thank you. And again, we advocate, Cure SMA helps to organize families in these states to advocate at newborn screening advisory committees about the importance of doing newborn screening for SMA and the impact that it has. So again, I want a shout out to the SMA community for all the work that everyone's doing in the states to push this locally. And Cure SMA is, I see us as really a facilitator, organizer. We're in the background trying to get the pieces to all work together. So thank you.
And then there's a question, is there evidence that increased awareness of SMA is changing testing of presumptive parents? And if so, what are parents doing with that information? Pre-implantation genetic testing, carried to term with expectation of treatment. And I don't know that there's evidence, so I can't state it from that point of view, but there's a few things that have happened. So one thing is that historically, going back decades, the American, let me think if I can do this right, the American College of Obstetrics and Gynecology had specifically stated that people should not get carrier testing for SMA. And a lot of that was due to the difficulties with having 2 copies of SMN, one show up on a carrier test, not being actually a good indication necessarily about what the chances of a child having SMA. And so in 2017, I think it was, after the success of nusinersen, the ACOG finally did change their position so that people should get prenatal testing. And since that time, there has been an uptick in the number of people who are getting carrier testing for, I'm sorry, I meant carrier testing a moment ago when I said prenatal. There's been an uptick in the people who are getting carrier testing. And so there are a lot more people who are being identified prenatally as having a child who has SMA. In the past 6 months, our clinic has learned of 2 families that were identified prenatally that they do have a child that is affected with SMA. And both of those families have decided to continue their pregnancy, knowing about what options there are now after birth. I had reached out to our prenatal team to see if that is a change from what has happened in the past. For example, in previous years where people electing terminations if they found out about an affected pregnancy. And to their knowledge, there really wasn't, they hadn't been seeing that. So it doesn't seem like it's a change, but my guess is that there probably is a lot more hope that's available now that there is a treatment and people don't have to undergo that really difficult decision of termination. And one final question, if we have time, cut us off, please, John or Mary, if we don't have time at this point. But final question is there anything that therapists can do to help advocate for newborn screening if they live in a state that does not have it?
If you are willing to testify, send me your information. Let me know that you're interested, and I will pass your information along to Maynard Freeze, our VP of Advocacy and Policy. And when he is aware of opportunities for you to testify, we are happy to invite you to do that. So to email me, mary@curasma.org or patientcare@curasma.org, and we're happy to get you involved.
Well, thank you. Really, this was a great start to the morning, and really appreciate it. It's obviously a very exciting time for us. So Carly and Mary, thank you very much for getting us launched.